All right, today we're getting into something really important happening inside the NHS. You see, the harm that keeps happening to patients and staff, it isn't some unavoidable tragedy. It's actually a problem that can be solved. It all comes down to a failure of governance. So let's break it down. Okay, let's start with a number that honestly tells you almost everything you need to know. 56%. That's how many NHS staff say they've gone to work when they were too unwell to do their jobs safely. It's a phenomenon called presenteeism, and it's a massive flashing red light. It's telling us that the system's safety net is stretched to its absolute breaking point. And this quote right here really gets to the heart of the problem. Governance delay does not hold risk constant. It compounds it. Think about that. When the people in charge put off fixing these issues, things don't just stay bad. They get worse. The risk builds on itself. It's this dangerous feedback loop where just doing nothing makes a bad situation catastrophic. So where do we actually see the first signs of this risk piling up? Well, it's in the human cost. And here's the thing. When a system starts to burn out its own staff, that's not just a consequence. It's a warning shot. It's a sign that it's about to start feeling its patience in a big way. Just look at this number, 7,055. That's how many suicides were registered in the UK back in 2023. It's an absolutely tragic, sobering figure. And the reason we're bringing this up is to give a sense of scale to the kind of risks we're talking about, and to highlight a really shocking difference in how we respond to different types of crises. Now, to really wrap your head around that number, think about it like this. It's the same as 3 short-haul airplanes crashing every single month. Can you imagine? If 3 planes were falling out of the sky every month, it would be a national emergency. There would be immediate wall-to-wall coverage, independent investigations, the works. And that comparison is used to show just how differently we treat these tragedies. And that's the whole point. On one side, you have aviation, where a single crash triggers this massive, coordinated response. But on the other, you have the health system, where this huge, ongoing loss of life is met with, well, what the source calls fragmented administrative processes. That gap, that governance disparity, that's the core of the issue we're talking about today. And this is the idea that changes everything. When doctors and nurses are burning out, it's not just an HR problem. It is a leading indicator. It's the canary in the coal mine, warning us that patient safety is about to fall off a cliff. Because, let's be honest, an exhausted, demoralized clinician is a risk to every single patient they treat. Okay, so we've seen the human cost, but the big question is, why is this happening? And the argument from our source material is pretty startling. The very tools the NHS uses to measure its own success are actually what's causing the harm. You see, this is a really fundamental point. Performance metrics, things like waiting time targets, they aren't just neutral tools for measurement. Nope, they are active behavioral drivers. They fundamentally change how people work, creating this incredible pressure that often pushes patient safety way down the list of priorities. And what that does is create this absolutely vicious cycle. It all starts with this intense pressure to hit a target. So what happens? People start taking shortcuts, unsafe workarounds, things like clock stopping, fiddling with records to meet a deadline, or discharging patients before they're really well enough to go home. Then, of course, patients get hurt. The clinicians who are forced to do this, they suffer from something called moral injury, and they burn out. Many of them leave. The workforce shrinks, which just heaps even more pressure on the people left behind. And the cycle starts all over again, but worse this time. And that term, moral injury, is so important here. This isn't just about feeling stressed. It's about the deep psychological wound that's inflicted when the system forces you to go against your own professional ethics, against your very sense of right and wrong, just to tick a box on a spreadsheet. This is what is gutting the clinical workforce from the inside out. So you have this pressure cooker environment, right? But it's made 1,000 times more dangerous because of the way the system itself is structured. The fact that the NHS is so fragmented isn't just inefficient. It's a design flaw that actively creates these predictable gaps where patients and staff fall through. And this is such a critical idea to grasp. Harm can happen without a single person making a mistake. The risk is literally built into the architecture of the system. It lives in the gaps between different organizations. You know, that space between a hospital and your local GP. Let me give you a perfect real-world example of what this looks like. A patient gets discharged from the hospital with a prescription, but it's only for a limited time. Now they're in that gap between the hospital and their GP. Who's supposed to continue the prescription? The handover fails, nobody picks it up. And the result? The patient's vital treatment just stops.
No one person is to blame here. It was the system's structure that failed them. So this all sounds pretty bleak, right? How do you even begin to fix a system that seems so fundamentally broken? You'd think it would require a whole new set of laws, a massive overhaul. But here's the kicker, and this is fascinating. The legal power to fix these problems already exists. It's just sitting there, not being used.
You hear this excuse all the time, right? The idea that local autonomy means the central government can't step in and tell a local trust what to do. Well, the source material calls that out. The reality, which is written into law, is that a power of enforceable direction is already on the books.
And let's be super clear about what this means. The Health and Care Act of 2022, an act of Parliament, explicitly gives the Secretary of State the power to direct NHS England. And it gives NHS England the power to direct the local health boards. The chain of command is there, especially when it comes to safety and governance.
So, what this all boils down to is that the problem isn't a lack of tools. We have the tools. The issue is one of governance execution. The power is there, sitting on a shelf, but the will to actually use it seems to be missing. Okay, so if the power is there, what would actually using it look like? Well, the source material lays out a really practical blueprint, no new laws required, for closing these dangerous safety gaps once and for all. First up, you use standardized formal agreements. They're called Memorandum of Understanding, or MOUs, to basically hardwire safety into those dangerous gaps between different services. These agreements would spell out in black and white who is responsible for a patient at every single step of their journey. They would mandate safe protocols for things like medication handovers and set up clear, enforceable steps for what to do when something goes wrong. The second part of the solution is to put governance guardrails around those performance metrics we talked about earlier. So what does that mean? It means a hospital couldn't claim success on a waiting time target without first proving that basic safety standards were met. It would force leadership at the board level to make sure that the incentives they create don't conflict with a doctor's professional duty to their patient. And a really key part of this is using something called the discordant signal rule. Now, this sounds complicated, but it's a really simple and powerful idea. A discordant signal rule just means you can't look at one piece of data in isolation. You have to look at your waiting time data, for example, right next to your data on patient complaints, safety incidents, and staff burnout. It forces you to ask the critical question: did we hit our target by making our service less safe? It's a way to stop the system from awarding results that look great on a chart, but are actually causing real harm on the ground. And that brings us to the final and, honestly, the most challenging question of all. If the legal tools to fix this broken system have been on the books for years, why, in 2026, are we still seeing these predictable, devastating problems? The tools are there, the harm is undeniable. The problem, as we've seen, isn't a lack of solutions. It's a failure of governance execution. And that leaves us with one last question. Where is the will to finally act?